Welcome to Gender Queries, a podcast about trans and gender diverse healthcare in Atlantic Canada. My name's Sam. My pronouns are they, them.
I'm Jess. I use they and she pronouns.
I'm AJ, and I use he, they pronouns.
And we're three medical students passionate about making healthcare more inclusive and affirming. And today's episode, we're going to talk about a foundational question: what is gender-affirming care? So whether you're a healthcare provider, student, community member, or just curious, this episode will lay the groundwork for understanding what gender-affirming care is. We'll talk about what it means medically and socially, and also just how people access it in Atlantic Canada. What do you folks think of when you think of gender-affirming care?
I feel like one of the first things that folks think about is hormones.
Yeah, hormones is definitely the first thing that comes to my mind. Medical and surgical gender-affirming care. But of course, there's way more to it than that.
Yeah, for sure. And I think it's so interesting because that is something that comes up as a common theme, is how much hormones and surgery dominates the conversation when it comes to gender-affirming care. And so if we want to be specific, the World Professional Association for Transgender Health, or WPATH, which sets standards for trans and gender diverse healthcare, describes gender-affirming care as a supportive form of healthcare that recognizes and affirms a person's gender identity, and they categorize it into three main areas: medical transition, social transition, and legal transition. A note here on language: transition is not a single event. Some people access all aspects of what WPATH outlined as transition being medical, social, and legal, and then some folks only do one or a few aspects of it, and it's also an ongoing and evolving process.
I'm Pascale Joëlle. You can also call me PJ. I identify myself as a transmasculine, non-binary, gender-fluid person, and I really don't care about my pronouns. There is not a definite end to one's identity. It's okay that it's always moving, and it's okay that you had a big milestone, a big stepping stone, and you feel very comfortable in yourself. And it's okay to want a little more, or to just continue exploring, because that's what makes us human, right? We change and we grow. So it is very important in all aspects of our life, including our identity.
That was Pascale, who we'll get a chance to hear more from in our upcoming episodes. But for now, let's chat a bit more about what social transition can look like. Like we said earlier, the conversation gets dominated by hormones and surgery, where social transition is usually one of the first steps in gender-affirming journeys and often happens long before somebody might see a healthcare provider. This can look like using the right name, changing pronouns, wearing different clothes, changing hairstyles, voice training, and using things like binders, packers, or tucking garments. And these are obviously incredibly meaningful practices that patients will utilize to help affirm their identity and support that gender expression. We had the opportunity to speak with Meaghan-Ray Peters, who has dedicated their time to researching one form of social transition: binding.
I'm Meaghan-Ray Peters. I'm a physiotherapist and a PhD student at the University of Alberta in Edmonton. I am also non-binary and use they, them pronouns. I'm a parent of a little kiddo, and I've been studying chest binding for the last 4 years, and before that had personal experience and community experience, secondhand experience, before even going to physio school.
How do you usually explain binding to somebody who might be unfamiliar with it, especially if you were to explain it to like a healthcare provider?
I usually say that chest binding is wearing a compressive tank top or using tape to flatten the chest or hold it tighter to the body. And this is usually done by trans men, trans masculine people, but can also be done by cis women. And it's mainly done after the onset of feminizing puberty, before being able to access top surgery, or after the onset of dysphoria, whenever people figure that out. And not everyone has access to top surgery, not everyone wants top surgery, so it can be a long-term management option. Most people use chest binding to manage chest-related dysphoria or gender incongruence, and it improves confidence, improves participation, improves gender congruence or euphoria, and it improves safety in public spaces. It decreases misgendering, decreases sense of threat, and also decreases suicidality. So it's a really important practice and really the only option for people to manage chest dysphoria. My work is done in the context of harm reduction and finding ways to help them bind as comfortably as possible with the least amount of long-term effects.
Definitely. I think that when it comes to a lot of the different aspects of social transition, harm reduction should be the focus for providers.
Definitely.
What are some of the most common physical effects or side effects that people might experience with chest binding?
There's lots of different symptoms that it can cause in all the body systems. So some of the most common are pain related. So back pain, chest pain, shoulder pain, shortness of breath, which we don't actually know why. The restriction makes sense, but there's minimal effects on the lung functions, which has been shown in research now. So we don't actually know where the shortness of breath is coming from other than the mechanical effort of breathing. So we're still working on that. And overheating is common because of the extra layers and the lack of breathability of the thicker material on the front. And some skin symptoms, so that can be itching, acne, abrasions, blistering, that kind of thing.
What are some of the things that you wish healthcare providers or students understood or knew more about when it comes to binding?
The main sticking point that I think most people run into is that it's not optional. So treating it like an opt-in behavior is really damaging for the relationship with the person who binds and your ability to help them manage symptoms. Another component of it is the safety aspect of it. Most people will not disclose binding to their healthcare provider because it's just so common to be told to stop, that it's inappropriate, that it's bad for you. And that's the community knowledge as well. They go into situations with healthcare providers knowing that it's just not a good idea to disclose.
For some folks, binding is what allows them to leave their house at all or to feel safe being out in public. And I think that's why it's so important that healthcare providers not only understand what binding is, but also respect and approach any concerns from that harm reduction lens. And I mean, there are guidelines in place to help mitigate some of those risks. Things like not binding more than 8 hours a day, taking rest days if possible, and then never sleeping or exercising in the binder. And with that said, we are human. We're laughing because this is obviously things that I've ignored myself when it comes to the recommendations. I've spent longer than 8 hours in a binder before, and sometimes that's just simply because you're having a busy day, but then sometimes it can be because you're having a very dysphoric day. And I've also worn binders to the gym every time I've been to the gym, and that's simply just because it helps me feel safe and it helps me feel okay. So yeah, sometimes it's hard to follow those guidelines, but I think that's what providers need to know and understand.
Instead of asking people to just follow the guidelines better, to follow the rules better, it's about finding a way that works for that particular individual to do what they can to make things a little bit safer while still allowing them to kind of get what they need out of that tool.
Yeah, exactly. And something else that Meaghan-Ray mentioned that I want to chat a bit more about is taping. There is something called trans tape, which is a medical grade kinesiology style tape. And some folks find that when they're struggling to either, bind for only 8 hours a day, or they're finding they're not able to take their binder off because they're busy, trans tape can come in as an alternative to binders because this is something that can stay on for several days. It can be something that can be showered in, worn during exercise like swimming, and also because you're not wrapping the tape around your whole chest, you have less restriction. And then some folks with sensory sensitivities also find that trans tape is more comfortable.
It's also important to be aware that some people bind and use tape at the same time.
Yes, yeah, definitely. And so just like binding with garments, trans tape itself is not risk-free. There's things that you should look out for, like tearing of the skin or blistering of the skin, especially if it's removed dry, rashes and allergic reactions. Moisture as well, just like with the binding garments, can lead to fungal infections. And then the obvious chest or rib pain that can also come with it being applied too tightly. And so some of the ways that healthcare providers should be aware of to kind of help mitigate those risks and allow for safer binding would be ensuring that folks are removing the tape with things like oil, so like baby oil, never removing it dry, and not taping over irritated skin. So ensuring that if a patient does have blisters that come from taping, that they're allowing time for that to heal before they tape again. And then also using things like nipple protectors before taping their chest tissue.
Is that something that people will have to buy?
Sometimes, depending on the brand. So trans tape used to come with nipple protectors. I'm not sure if it does anymore. But as long as there's some kind of protection between the nipple and the tape itself, some folks will use the other side of the tape and put the non-sticky part down on their nipple, or tissue before the tape and things like that. So it can be DIY.
A cool thing about trans tape is also that it can also be used to create the appearance of breasts or to accentuate breasts.
Are there any forms of binding that are unsafe and should not be used?
Yeah, definitely. And I'm glad you brought that up. There are big no's, things like elastic bandages, ACE bandages in particular, and some other ways that folks have gone about binding are things like duct tape, plastic wrap, or saran wrap. And these are very dangerous. They're material that don't breathe, they don't flex at all, and can severely restrict blood flow and impair breathing. And they can cause rashes, bruising, and even rib fractures. I think it's important to realize why folks might also turn to those alternatives, and often it's because they either can't afford a binder or they may not feel safe purchasing a binder or having a binder delivered to their home, maybe because they're not out to family members, and so these are just alternatives that they see. But yes, they're big no's, and physicians should be aware of that and ensure that patients are not going about binding in those means and trying to help find and access alternatives for them. One really cool resource in Halifax is the Transformation Closet, which is a program that offers free gender-affirming gear across Nova Scotia. But again, that is something that they will deliver to you, so there are those situations where there might be some concern with not being out to family members.
Unsafe binding often comes into play, I feel like, with youth especially, and youth who don't have as much access to resources. They just don't have much of an option. They might not have transportation, which I think is why programs in schools and things like that are especially important.
The next tool that I wanted to chat about for gender affirmation is padding. Padding is when somebody uses things like hip pads, butt pads, or bras with inserts to create or emphasize certain body shapes. That can range from things as simple as soft inserts to something even as elaborate as silicone prosthetics, which are actually designed to mimic the natural body, which is pretty cool. Similar to padding, there's what is known as packing. This involves wearing a soft object to essentially create a bulge in the groin area. On the more accessible end of things, sometimes folks will do a DIY method, like a rolled sock, or using a condom and filling it with hair gel, knotting the end and placing it in their underwear. There's also commercially purchased packers. These are items that you can buy that are designed to look like a penis. They can come in different sizes and colors, and sometimes with or without foreskin or testicles. They're usually held in place by a jock strap or special harness, or simply just tighter underwear. And some are used for sexual penetration, and then some are used for standing to pee.
Are there any risks to packing?
It might not seem like there's much of a risk, just simply based on how it works. But there are some things like skin irritation or chafing. And so a common solution to that would be wearing double underwear, putting the packer between, having particular underwear where the packer sits inside a pocket. And then rarely you can see things like UTIs if hygiene is not properly maintained, especially around those stand-to-pee devices. And again, healthcare providers should be aware of what packing is and understand that it's a completely normal and valid way that people affirm their gender, so don't make it weird. Another method for affirmation that is commonly done is tucking. Tucking is basically when someone repositions the penis and testicles to create that flatter appearance in the front. That typically involves guiding the testicles either up into the inguinal canals or pulling them back with the penis, and then tucking them between the legs and securing it with either things like tighter underwear, a gaff, which is a garment that's specifically made for that purpose, and then sometimes trans tape. It's not always easy to talk about, just like packing, don't make it weird, but it's something that does matter. I also want to make a note on language there, because some folks who tuck may use different language for their anatomy. They may not be comfortable with the terms penis and testicles, especially if that anatomy does cause them significant dysphoria. So again, just as a provider, being aware of that. Also, a reminder that just like with stand-to-pee devices, there can be a learning curve. And so just advise patients to go slow, trust their body and listen to it. And, it can take time to practice tucking safely and comfortably. But what's really important to note here is that it should never feel overly uncomfortable or painful. If a patient reports feeling faint, nauseous, or experiencing pain, advise them to stop and take breaks and maybe try again later.
So, are there any risks and are there guidelines around, how long you should do it for?
We specifically see things like skin irritation, and that can come from various reasons, often just trapped moisture, especially if they're sweating a lot. UTIs can be a big thing as well, and that often comes from folks reducing their fluid intake or not urinating when they need to because they're either avoiding public restrooms altogether or they're just avoiding untucking. And then things like consistent long-term tucking can lead to nerve damage from compression, restricted blood flow, and fertility concerns, especially where you place the gonads into the inguinal canals with that prolonged increased temperature there. So it's important to advise patients about future sperm banking and counsel on that option. Regarding guidelines for time limits when tucking, there isn't any universal recommendation for length of time, but most community resources and health recommendations emphasize moderation. It's really about listening to your body and trying to limit tucking to short periods, taking breaks when possible, for example, when you're at home or in bed. But like I said, just like binding, it's really about listening to your body.
Safety is always a thing that's on my mind, and I feel like tucking is something that, for some people, in addition to being gender affirming, it might be a matter of safety.
You make a really good point, yeah. I was reading a paper from the Annals of Family Medicine published in 2024, and they were reporting how trans feminine and gender diverse people use tucking as a way to reduce that visibility, avoid unwanted attention, and feel safer moving through public spaces, especially in environments where a visible bulge, as one person puts it, can lead to stigma, harassment, and violence. This was a relatively small single-site study, so it doesn't capture every trans feminine experience, but when we situate it within the broader Canadian context, the safety dimension really becomes more clear. We know from a Statistics Canada report in 2023, hate crimes motivated by sexual orientation increased about 70% compared to the previous year. Looking at the longer trend from 2016 to 2023, that increase is even more striking, with 338% rise. But more specifically, Stats Canada has also highlighted that incidents motivated by hatred towards gender-diverse folks tends to be more violent in nature, with about 80% involving a violent offense. Something that really stood out to me while reading these reports, and something that I think is important for listeners to understand, is how much of this violence and hate never shows up in official crime statistics. The Eagles 2023 Pride Unraveled campaign tracked anti-2S LGBTQIA+ protests and online hate across Canada, and within just the first 3 months of 2023, they documented over 6,000 instances of violence, unreported threats, and attacks on that community. And none of that was captured in police-reported hate crime data. Going further, when we look at lived experience data, that picture becomes even clearer. The TransPulse Canada National Survey from 2018 found that within the previous 5 years, about 16% of trans and non-binary respondents had experienced physical assault, and 26% had experienced sexual assault. So yeah, exactly to your point, AJ, about the safety element. I think that when we talk about violence and fear and safety, we can see that it is tied to visibility and gender expression so intimately. Many trans and gender diverse people, how they move through the world isn't just about identity, it's also about that protection and that comfort and that survival. The ways that people express their gender can be shaped by what helps them feel safe and helps them feel seen or at ease in different spaces.
These tools are really important for some people, but not everyone needs to bind or pack or tuck.
For a lot of folks, I feel like it's knowing that you are perceived as a different gender by the people around you and by your friends and family in your community. And that is kind of at the heart of what social transition is about.
Yeah, and just kind of going back to that whole idea of what transition means, and it means something different for everybody. That could mean I'm going to change my clothing, I'm going to change my hairstyle, and I want somebody to refer to me by a different name and pronouns. And maybe that leads to the end of that journey for them.
And that endpoint might change, and it might not.
From personal experience, some people's gender is an amorphous blob, and that's okay.
Love it.
So we talked about social transition. We know that most people think about medical transition when they think about what transitioning means. What are the different aspects of medical transition?
Some of the big aspects are things like puberty blockers. Jess explores this in depth in the pediatric episode, but this is essentially used for youth experiencing dysphoria during early puberty. These are fully reversible and give time to explore identity without the stress of unwanted physical changes. Another aspect is hormone therapy. I had the opportunity to speak on this with Dr. Atkinson.
My name's Dr. Sue Atkinson. I'm a family doctor. I work at Dalhousie Family Medicine and also the Halifax Sexual Health Center, and I've been providing gender-affirming care for probably 30 years now.
What types of estrogen and testosterone are commonly used when it comes to gender-affirming care in your clinic?
Probably the most common estrogen that we use is estradiol tablets, and people either take those orally or sublingually. There can be a difference in their serum levels depending on which way they take it. So if someone is saying, well, I've been taking it orally, I'm going to try sublingual, I ask them to let me know, because it may be enough that we would have to alter their dosing, particularly if it wasn't part of the titrating up part, they're on their full dose. It has been quite popular in places like BC to use injectable estradiol. It is becoming more popular here and more likely a thing that people will opt to do. It's challenging insofar as in Canada, there is no off-the-shelf or, pre-prepared injectable estradiol. It needs to be compounded, which adds cost. Additionally, some drug plans won't cover compounded items. Even if you get Canesten compounded with hydrocortisone, it might not be covered by your drug plan. But there are a couple of places, at least on this side of the country, like there's a Maple Pharmacy in Moncton that will compound it, and Boyd's here brings it in so that people can just go and get it at the pharmacy. Certainly topical gel or the patches are quite common, particularly in people as they reach older ages like 40 plus and the ages of menopause. We're more likely to switch to the topicals because they are lower risk in some ways for thrombosis and that kind of thing. And we know risk of those things can go up as people age.
When you have patients that are going from oral to sublingual for the estradiol, is there a reasoning behind why they make that choice?
It's felt to maybe be a little bit safer. Sublingual is kind of like topical. And there is a lot of information on the internet that may or may not be true. So there are some people who feel that it works better. There's been no studies, as far as I know, that suggest that that's the case. But, people are hoping that it will work well and fast, because usually by the time people have chosen to move forward with hormones, they are way behind where they want to be to start with. But it may decrease some risks of thromboembolic disease. Some people will find that it will actually cause the skin under their tongue to become a little bit more swollen because estrogen tends to plump up mucosa, right?
Right.
Sometimes people will say, no, let me go back to taking it orally. So it's a personal choice mostly. Sometimes if I'm really having troubles getting someone's estradiol level up, I will ask them to try sublingual. On the testosterone end of things, most people end up starting on injectable testosterone because it's affordable and it masculinizes well, like it causes the changes that it needs to cause well. There is a testosterone tablet. It is not helpful. People, if they are worried about needles, they will often ask, well, what about the tablet? Unfortunately, testosterone doesn't do well in stomach acid, so the levels are very variable, and it doesn't tend to lead to amenorrhea, which is, of course, part of what many people hope for in starting on testosterone. There is a testosterone gel. It's great for maintenance, but it seems to take longer for some of the changes that people are often eager to get. Sometimes in people as they grow a bit older, we may change them to gel. It's more expensive. And depending on the dose that you're on, it can be challenging to have enough body surface area to rub it into. You also have to be a little bit careful around your person who may not want testosterone as a major hormone in their body, because it could potentially get absorbed if you were to snuggle up right after putting it on. So you have to just be cautious of that. So a discussion as far as the thinking that goes behind it is about, are they okay with injections? If you've got someone who lives rurally and they don't have a practitioner or anyone around them who can give the injection, they're needle phobic, they can't do their own, then that might change what you decide. And similarly, in some ways for women, is that most people start on oral. Are they needle phobic? Do they want the injections? Is that better for them or not? So it's often a discussion. And if I were starting someone who, let's say, was in their late 50s, I might be a little bit more likely to choose a topical, especially for the estrogen. For testosterone, we might say, let's do 6 months or a year of the injectable to get things started, but then switch you over to topical, just because in older adults, it's a lower risk profile to use topical of either hormone.
How do you go about approaching dosing for estradiol and testosterone?
I more or less follow the Sherborne guidelines. I tend to go a little bit slower only because of the practicality of when people can get appointments, right? So I often will say, let's do this for 8 to 12 weeks, and then we'll recheck your blood work. If we do it in 4 weeks, they're not going to get an appointment with me. They may not even get a blood work appointment. And ultimately, you're trying to mimic a little bit a puberty, right? And puberties do not happen overnight. It takes a while. Same with testosterone. I mean, I usually, unless there's a reason to start lower, I usually start people on 40 milligrams and then bump them up every 3 months or so, much for the same reason. Mostly what we're looking for is effect. We also use blood levels, mostly to make sure we're not going supra-physiologic in the
Right.
dosing. The normal range for testosterone for male individuals is between 8 and 29, something like that. So you don't want someone at 40, right? Because that can potentially be problematic for their health. You're looking at levels to make sure you're not supra-physiologic, and then you're looking at what changes are people getting. And we can't promise that more estradiol, for instance, will cause more breast growth, or more testosterone will cause more beard growth. There is a certain amount of genetics. And I
Right.
usually tell people, if you come from a family with women with larger breasts, you might have larger breasts. If you come from a family that everybody are A cups, you're not going to be a C cup. And if no man in your family can grow a beard, then chances are, even
Yep.
with adequate doses of testosterone, that may not be what's going to happen for you. So genetics do play a role too.
For sure. We know that acne is a major issue that can come with transmasc folks. And medications like Accutane have strict rules when it comes to contraception and pregnancy in general. Are there any particular requirements or things that you have to navigate for folks who are on testosterone and want to take Accutane? Are there certain conversations that you have around that?
Yeah, I think you have to give people the information and then help them assess their risk for pregnancy. So, for instance, if you have someone who is on testosterone, you've decided they need to go to Accutane, they have a partner who doesn't have any sperm, and they have no interest in partners who have sperm, like, their orientation is such, then you can probably say, well, this is what everybody's worried about. What do you think your risk is? And if they say, no risk, I have no risk of getting pregnant, I'm not going to make them take birth control. But, you can certainly have people who, do have partners who have sperm who are at risk, in which case then you do have to talk to them. And usually most of those folks would end up choosing a progestin-based birth control, either Depo-Provera, Nexplanon, or a hormone-containing IUD as a form of birth control in general. But, if they're at risk and going on Accutane.
When it comes to dysphoria and gender incongruence, what are they looking for when assessing somebody now versus before there was the informed consent model?
Years ago, there was certainly more of a, if you don't look the part, you're not serious about this. So, if you had someone who came in with their long coiffed hair and fingernails and earrings and, the traditional feminine kind of attire, saying, hey, I'm a male person, they might more likely be met with skepticism. And they always were insisting on a real life experience, which is freaking dangerous for the most part. But that's what they would almost require people to have a real life experience, go and dress and be in the role of your gender identity and come back and tell us how it went. I don't know. So certainly that's one thing that I've noticed, that there's less reliance on external proof and more meeting people where they're at and sort of saying, well, you know yourself best. And if this is true for you, it's true for you, that kind of thing. The main thing as a health professional is making sure that, and this is not meant in a paternalistic kind of way, but making sure that hormones, as an example, is in the individual's best interest. And that usually means making sure that there isn't a diagnosis that might explain the way they're feeling that is not about gender dysphoria or incongruence. It's because they have active psychoses, or they have body dysmorphic disorder, or, some things that are pretty rare, but you just kind of want to make sure. And 99% of the time, if not more, it's just your average run-of-the-mill gender dysphoria.
What do you think are some of the most important things that other healthcare providers should know when it comes to prescribing or managing hormones and just gender-affirming care in general?
It is in the wheelhouse of family physicians. It's a message that needs to keep going out there. It can feel a little medically scary at first, but it's not. And most people will have someone in their practice who needs injectable testosterone because they have hypogonadism. And most people will be prescribing estrogen as either menopause hormone therapy or contraception. We know about those medications. We know the risks and the benefits and the side effects and all that kind of stuff. So it's not completely foreign. It's just a matter of sort of having an approach like anything else. My colleagues who all of a sudden have a patient who is presented to them and they want to do the work, and so they come to me for advice, and I will give them all the advice they want, but I'll also say, read the Sherborne guidelines, because they really are straightforward, meant for primary care. It's not a tome, it's something that's quite readable and covers all the things that you have to think about, has some very practical tables. And the Rainbow Health Ontario, so you want to provide hormone therapy, it takes you through, and it's based on the Sherborne guidelines. That's another good resource for people.
Before we switch gears, I just wanted to take a moment to highlight those Sherborne guidelines and the Trans Primary Care Guide that Dr. Atkinson mentioned. They're both part of the Rainbow Health Ontario website, and the Sherborne guidelines themselves are quite comprehensive. But the Trans Primary Care Guide is an online interactive tool that lets providers click through different parts of care. So you can walk through getting familiar with terminology to planning hormone therapy, and the follow-up in a very step-by-step way. It's essentially designed to feel less like a dense textbook and more like a practical walkthrough for that primary care.
We talked a lot about what gender-affirming care is. How does someone go about accessing that, especially in Atlantic Canada?
That's a really good question, and it's really very individualized. It's important for us to know that when we talk about medical transition, there really isn't one single pathway. But to answer your question, generally speaking, gender-affirming care in Atlantic Canada usually begins in primary care. That might be a family doctor, a nurse practitioner, community clinic, and then, like we mentioned earlier, providers follow an informed consent model for hormone therapy, which really means that people don't need to meet specific checklists or prove their gender identity in any way. The focus is really on understanding the benefits, the risks, and what feels right for that patient. And then from there, the providers can either start care themselves, like prescribing hormones, or make referrals to endocrinology or surgical programs if that's what the patient wants. Now, we won't be going into gender-affirming surgery in this episode. We'll be unpacking that in a future episode because there's a lot of nuance there. But to better understand how coverage works in Nova Scotia, I spoke with Gabriel, who is the navigator with Pride Health.
My name is Gabriel Enxuga. I use he, they pronouns. I'm a social worker and I work as a navigator with Pride Health. So for folks who aren't familiar, Pride Health is a program of Nova Scotia Health and the IWK. And we work within the healthcare system to make it safer, more inclusive, more culturally safe for 2S LGBTQIA+ folks across Nova Scotia. My role is as a navigator. So really that looks like providing navigation support to community members, patients, and also healthcare providers. Gender-affirming care is covered through MSI, but the coverage is limited. So certain services aren't covered, like hair removal. And I believe that the coverage offered through MSI should be in line with the WPATH standards of care, which really recommend medical treatment for gender dysphoria. And so I think if we understand it in that way, it doesn't make sense to choose which aspects of gender dysphoria we treat and which aspects we don't treat. All aspects of gender dysphoria should be treated, especially for hair removal, where it's actually necessary for certain surgeries. So patients might receive approval to, say, have a vaginoplasty or a phalloplasty, and hair removal is a prerequisite for that surgery. But the actual cost of hair removal is not covered. So people may end up paying $1,000 to $2,000 or $3,000 for hair removal pre-surgery. And for folks who are on low income or limited income, it's actually just not affordable. So yeah, I would say lack of full coverage of MSI is a big gap. And just generally, we don't have pharmacare coverage. I think that's like a big gap in our healthcare system broadly, but is also a barrier for folks, especially for certain medications like puberty blockers can be quite expensive, like several $100s. And so that is a barrier as well. The other barrier is just higher psychosocial needs among queer and trans communities. There is a lot of data and statistics out there that show that to us LGBTQ people, and particularly gender diverse people, experience higher rates of housing insecurity, food insecurity, financial insecurity. And so that just generally makes it more difficult to access healthcare. It's more difficult to attend appointments. It's more difficult to pay for medication. And you're just stressed. You're just in a state of chronic stress. And if you look at the Maslow hierarchies of needs, when you don't have a stable place to sleep or food to eat, it just makes it hard to be well and to be healthy. So I think that we also need robust social programs to support people as well.
Gabriel really highlights the difference between knowing what is covered on paper versus what that coverage looks like in reality. They paint a good picture of why navigating gender-affirming care is more than just knowing what exists. It's also about knowing what's covered, what isn't, and then where folks end up having to go to fill in those gaps themselves. I had the opportunity to speak with Jocelyn in PEI, and she spoke on how this looks a little different.
My name is Jocelyn Adams. Pronouns are she, her, and I'm the Executive Director of Gender-Affirming Care Prince Edward Island and one of the co-founders of Gender-Affirming Care Prince Edward Island.
When it comes to gender-affirming care in PEI, are you able to speak to what kinds are covered publicly?
Under our new 2023 policy, we intentionally wrote it pretty broad, that it aligns with WPATH Standards of Care 8. So whereas a lot of provinces will reference the standards of care in their policy, they don't necessarily align with the policy and the recommendations included in it. So they will kind of cherry pick, we'll take WPATH's recommendation for top surgery, but not the recommendation for bottom surgery and not the recommendation for this. And in a lot of cases, it's a lot of the assessment criteria, but not the treatment part. And you'll have to excuse my language of patient assessment, diagnosis, and treatment, because that can all be viewed kind of negatively. But in a physician's world, there's a billing code. It has to come down to these sorts of things. So when it comes down to WPATH and their treatment recommendations, only Yukon and Prince Edward Island follow the recommendations in WPATH Standards of Care. So if it's listed in the standards of care, it should be covered on Prince Edward Island. And I say should because that's the way the policy is written. There might not be explicit pathways laid out for every little thing that's in there because it hasn't happened yet. The policy's new. So the first time someone in province applied for FFS, facial feminization surgery, there's going to be a longer wait associated with that. We have to line up surgeons. We have to line up billing. What billing code do we use for FFS? What does FFS even mean? That's a collection of any number of things depending on the patient. In some cases, the codes exist, like for rhinoplasty, for cis people, but not for gender-affirming care. So the process is so much more involved than simply, we cover this, yes or no. We say, yes, we do, we want to, but then Health PEI as a health authority, we have to figure it out. So it's a bit of a process, but in general, if it is in the standards of care, we will find a way to make that happen. Like FFS is covered, breast augmentation, breast reduction, mastectomy, bottom surgery, voice therapy, voice surgery, hair growth, hormone usage is actually covered through our drug plan now. So if you don't have a private drug plan, your hormones are covered. Surgeries out of province, your meals when you're out of province are covered. Your travel is not, but we are kind of linked up with Hope Air, and they're a charity that will fly people out or, bus them out or whatever they need.
Hearing from Jocelyn really reminds us that access to gender-affirming care isn't just about individual providers. It's shaped by those policies, funding decisions, and whether or not systems fully align with those standards of care. When we ask the question, what is gender-affirming care? I feel like what we really hear from folks that we've talked to is that there isn't one single answer. Gender-affirming care could involve hormones, it could involve surgery, or it can simply be about using the right name, the right pronouns, and ensuring someone feels safe to be themselves in the world. For many people, this is not a linear journey, and it may not have a fixed endpoint. It's also something that's allowed to evolve over time. But what is consistent with gender-affirming care is that it's really about meeting people where they're at and listening to what they know about themselves and supporting them in ways that reduce harm and increase safety. So for healthcare providers and learners, we really hope this episode helped demystify what gender-affirming care actually looks like and really reinforce that much of this care already fits well within primary care, guided by that informed consent model and existing clinical framework. We also want to take a moment to sincerely thank all of our guests who shared their time, expertise, and lived experience with us in this episode. You'll find more information about our guests along with their work and relevant resources in the show notes, where you will also find references, additional learning material, and a full transcript for this episode. In the future, we'll dive deeper into topics like gender-affirming surgery, pediatric care, disability, and chronic health, and how folks navigate that in Atlantic Canada. That's all from us at Gender Queries.